wanted to discuss this point with you because adenoidectomy is one of the most common procedures that we do in our practice every day. And I wanted to highlight many important points that we need to revise and to put in our minds while we are doing this procedure. There are a few tips and hints about how I do it actually, but this was not my main interest. My main interest is to revise things that we may miss during examination of the patient, during investigating the patient, that I want to put stress on. This is our institute. First, a good surgeon is a good anatomist. So you have to know anatomy of the area that you are going to deal with. You have to know the anatomy of the area you are going to perform surgery on. The adenoid lies in the nasopharynx, and the adenoid, as we all know, is part of the lymphoid tissue of the Waldeye's ring that protects our upper airway system and forms part of the most important constituents of the immune system in the early childhood. In order to know how we are going to perform adenoidectomy, you have to understand this anatomy. This is the adenoid bag. What lies behind us, what lies beneath us, what we will be actually pressing against while we're using our adenoid curette is this area. So we have to understand what's the anatomy of the nasopharynx. The nasopharynx is lined superiorly by the sphenoid sinus, and from backwards by the basal part of the occipital bone, and by the first cervical vertebrae. So what lies beneath us, beneath the lymphoid tissue, is this part of the bone, which is the basilar part of the occipital bone, covered by the pharyngobasilar fascia. So when you are curetting the adenoid, you know that you are actually going to remove the mucosa covering the adenoid, and then you are going to remove the adenoid tissue, and then your underlying tissue will be the bone covered by the pharyngobasilar fascia. From the endoscopic point of view, this is the area that you will work on. This rectangular area is the area you are going to work on. Your lateral margins while you are doing adenoidectomy will be the torus tuberous and the fossa of Rosenmuller bilaterally, superiorly the basi-occiput, and the ostichial tube orifice also bilaterally. So bilaterally is the ostichial tube orifice, the torus tuberous, and the fossa of Rosenmuller. Superiorly is the basi-occiput, and inferiorly is the Basavant's ridge. And this is an area we are going to tell in a moment, because it's an important site that you have to take care of. You have to remove your adenoid within this box. If you go laterally, you are going to injure the ostichial tube and the torus tuberous. If you go downwards, you're going to injure the Basavant's ridge, and all of this is going to give some harm to the patient. This is another endoscopic view. You can see this is the torus tuberous, the ostichial tube orifice, the fossa of Rosenmuller. This is the vomer, the quena, and the posterior end of the inferior turbinates, and this is the adenoid. This square area is the area you have to work with. You don't have to go laterally or superiorly, or you are going to injure any of these structures. What about the Basavant's ridge? The Basavant's ridge is the lowermost fibers of the superior constrictor muscle of the pharynx. Why is this part important while you are doing the surgery? Because in many of the children, during speech, the velopharyngeal valve, the soft palate, will close towards the posterior pharyngeal wall at two sides, either at the adenoid itself or at the Basavant's ridge. So the lowermost fibers of the superior constrictor muscle of the pharynx. So when while the patient is in speech, the posterior pharyngeal wall, the soft palate is going to raise upwards and backwards to touch and reach the posterior pharyngeal wall. The area of contact will be, in children, will be the area of the adenoid, so it's a velar adenoidal contact, or the area of the basaphenous ridge. So if you injured, this is the adenoid, this is the area of the basaphenous ridge, this is the lower part, lower fibers of the superior constrictor muscle, the fibers. No, it's the lower fibers. Okay. So while you're doing adenoidectomy, you have to take care of this area and not put it into danger or injure it. Otherwise, you're going to have a problem with the patient during speech. This is where you're going to put your curette. The curette is actually resting on the basal, basal part of the occipital bone and on the vomer. So a little bit of history about adenoidectomy. Adenoidectomy is not a new procedure. It's a procedure that has been done for a very long time. And the first doctor who actually noticed the importance of the presence of the adenoids and the importance of removing the adenoids in improving the health of patients was Dr. Meyer in 1886. This is one of his photographs showing the improvement in the facial appearance of his patients after doing adenoidectomy. This is before and this is after. All the patients have open mouth, they have this apathetic look, and this is what he achieved by doing adenoidectomy. So it's an old procedure. However, the procedure in the past used to be done in a sitting position, used to be done without anesthesia, and it had to be a very quick procedure. One of the reports from New York in the late 19th century said that the 81 students of one school underwent adenoidectomy in 84 minutes. That means they used to do the procedure in only 1 minute. So what are the indications that we should think of if we are going to perform the adenoid surgery? Number one is persistent bilateral nasal obstruction. Persistent bilateral nasal obstruction with all its sequelae. Open mouth, repeated chest infection, affection of the daytime sleepiness, affection of the mentality and health of the mental health of the children. And as you can see, this is what a child with a bilateral nasal obstruction due to the adenoids will look like. He will have an elongated and tall face, and he will have a small upper lip, a large lower lip, open mouth, narrow nostrils. This is what we call the adenoid faces, and they used to call it the apathetic look or sometimes the idiot face. What are the other indications? Sleep disorder breathing is one of the most important things that we should think of while doing adenoidectomy. A child with snoring, obstructive sleep apnea, or any other type of sleep disorder breathing with its sequelae is a major indication for adenoidectomy. Otitis media, whether it is repeated attacks of acute otitis media, whether it is secretory otitis media, or even chronic otitis media, if the patient has an enlarged adenoid, you should think of removing it. Number 4 is the recurrent infection. Actually, it's very difficult to decide if the patient has recurrent infection in the adenoids. You can diagnose easily tonsillitis, but it's not easy to diagnose chronic or recurrent attacks of adenoiditis. However, we usually think that if the part of the Wilder's ring, meaning the tonsils, are inflamed, you are going to have adenoiditis with it. So if you have repeated infection in this area, you should also think of doing adenoidectomy. And of course, rhinosinusitis in children. One of the main techniques of management of rhinosinusitis and recurrent rhinosinusitis in children is doing adenoidectomy. This photo was taken from one of the books. It says this is an intraoperative photo. Would you perform surgery for a child with this very small adenoid? I mean, the choana are both opened. So would you do surgery for a child like this? Yes, I would do surgery for a child like this if I'm going to do a tonsillectomy. There are no studies that support this type of management, but this is what we usually do. If your child is going to do tonsillectomy, you will usually do adenoidectomy with it, because you are afraid that after doing tonsillectomy, the adenoid is going to enlarge in size and be prone to more infections. This is number one. Number two, if this child has secretory otitis media, even though the adenoid is not large and it's not actually mechanically obstructing the eustachian tube, however, it's well known that a bacterial biofilm covering the adenoid can be one of the causes of recurrent infection in the eustachian tube or blockage of the eustachian tube and secretory otitis media. So you can do surgery for a non-blocking adenoid.
دكتور هي الصورة دي يعني متغيرة ازاي؟ مش عارف.
This is a mirror view. This is a mirror view, intraoperative mirror view. عشان كده الصورة مقلوبة. Okay. What are the contraindications? These are relative contraindications. There are no absolute contraindications for adenoidectomy. Coagulopathy and bleeding tendency. Of course, you can prepare your patient before doing the procedure. Cleft palate, if the patient has already cleft palate or has a repaired cleft palate, or the patient has velopharyngeal insufficiency. However, these are relative contraindications, because if you have a child who has bilateral nasal obstruction and at the same time he has velopharyngeal insufficiency, or he has undergone cleft palate surgery before, you have to deal with the problem, and we can do this by doing what we call a superior adenoidectomy, in which we remove only the superior part of the adenoid tissue and leave the lower part of the adenoid, the part that's going to be in contact with the soft palate during speech. So you can still do adenoidectomy in a child with cleft palate. We have been always taught never to do a adenoidectomy in a child with cleft palate, or has undergone a cleft palate repair, or with velopharyngeal insufficiency. A child complaining of symptoms of bilateral nasal obstruction due to the enlarged adenoid can be treated by only removing the superior part of the adenoid tissue and leaving the rest, leaving the inferior part, which is going to be in contact with the velum during speech. Also, we have to know that there is no age limit for adenoidectomy, especially for cases in which there is obstructive sleep apnea. So in a child with obstructive sleep apnea, you have to deal with it. It's a problem that's going to affect his life, and there is no age limit. The youngest child that I have operated on was about 5 months old. He had obstructive attacks not only during sleep, he had obstructive attacks during being awake. And his mother and father could not go to sleep because they take shifts watching over him, thinking that he's going to die because he's always obstructing. So a child like this, you cannot leave him. You cannot follow what we have been told before. Don't do surgery before the age of 1 year. Don't do the surgery before the age of 2 years. This is not even supported by scientific research. Now, how can we examine a child with an enlarged adenoid, or somebody who's going, or we suspect that the cause of his nasal obstruction is the adenoids? We have two tools for doing this, either the nasopharyngoscope or the plain lateral X-ray. To me, I think now in our time, we should always consider doing examination by the flexible endoscope and even by the rigid endoscope if the child is above the age of 5 years and he can tolerate it, because the nasopharynx is a 3-dimensional space, and to have a look by a 2-dimensional image like the X-ray on a 3-dimensional space, you will never get an accurate image. So the only accurate way that you can assess the size of the adenoid, whether it is obstructing or not, whether the patient is actually in need for surgery or not, is by doing the nasal endoscopy. This is an example of a child who has already undergone adenoidectomy. He's coming back with symptoms of nasal obstruction, and this was a choanal adenoid. You cannot get, you may miss a choanal adenoid in a plain X-ray, but you will never miss it while doing the nasopharyngeal endoscopy. And I would recommend that any patient who has already undergone adenoidectomy and is coming back for bilateral nasal obstruction or even unilateral nasal obstruction, he should be evaluated only by nasal endoscopy and not by plain X-ray. And I will give you an example. This is the plain X-ray view, that lateral view, soft tissue to detect the adenoid. And here is the soft tissue of the adenoid. It's a large one. There are some precautions we have to know it before while we are doing this type of X-ray. The child should have his mouth open, and this is because we don't want the child to swallow. If the child swallows while he's doing if your mouth is open, you cannot swallow. Because if your mouth is closed and you're going to swallow, the soft palate is going to move upwards and it's going to hinder the view of the adenoid. So the child should have an open mouth. And also the child should have an extended neck, because when your neck is extended, the angle, the mandible is pushed away from the nasopharynx and away from the side of the area of the nasopharynx. If you don't get these precautions, you will usually get false positive and false negative results. So plain X-ray is not usually a reliable tool for assessing the size of the adenoid. However, if you have a child of the age of 1 year, 2 years, and it's very difficult for him to undergo examination with a flexible endoscope, you can do a plain X-ray. This is an example of what I was saying. If you have a look at this plain X-ray, you would see that there is an area of adenoid, and you may think, I would go and do adenoidectomy for this child. This is a child who were coming with a recurrent symptoms of nasal obstruction after adenoidectomy. One of our colleagues were going to submit him for adenoidectomy. We had a look with the nasal endoscope. There was no adenoid tissue at all. So you have to respect that there is fallacies in the plain X-ray. So don't take it usually, don't put it as your first line of diagnosis. Always use the flexible endoscope. Would we do a CT scan for diagnosing the adenoids? Usually not. It's usually detected accidentally when we are taking CT scans for a patient with chronic rhinosinusitis, or for sometimes in patients with chronic ear problems, when you can detect and find this kind of enlarged adenoid. Whenever you are examining a patient with a chronic ear, especially if he's a teenager around this age, you have to look, and you are doing a CT scan for him, please have a look at the nasopharyngeal area, because if you have an adenoid and you don't remove it, this is going to affect the results of your ear surgery. There are some areas that requires special attention. Patients with Down syndrome. A child with Down syndrome who's going to be subjected for a adenoidectomy should be taken under extreme care, because children with Down syndrome have specific criteria. One of them, if you are going to put this patient under anesthesia, your endotracheal tube size should be at least one size less than the usual size for his age, because many of these patients will have subglottic and tracheal stenosis. So the size of the endotracheal tube will be different. These patients will usually have a tongue-based problems, and they have enlarged tongues, and they may need post-operative care and post-operative hospital stay, not like every other the usual adenoidectomy cases. Also, Down syndrome cases may have the problem of atlantoaxial subluxation, and this will you have to put this in your mind while you are performing the surgery, because you have to do the surgery in the minimal amount of extension of the neck, because you don't want to put your patient into danger. Also, you have always to consider the cardiological problems that may be present in patients with Down syndrome. Patients with craniofacial anomalies, always when you have a patient with craniofacial anomalies, you have to consult your colleagues in the genetic departments. You have to consult other specialties, just to make sure that these problems are not the only problems that the patient has. And sometimes the cause of open mouth and the cause of snoring and obstructive apnea would not be that the enlarged adenoid. It would be because of the craniofacial problem. Also, I would like to put your attention to a very important syndrome. It's called the velocardiofacial syndrome. The children with velocardiofacial syndrome may have looks that is a little bit similar to the adenoid facies. However, these children would have a very important finding, which is this. If you do an endoscopy to a child with velocardiofacial syndrome, you may get this apparent course of the carotid artery. And the carotid in these children may be passing just behind the adenoid tissue. So if you do an adenoid curettage to this child, you may injure his internal carotid artery. Also, you should always consider other causes of nasal obstruction. Sometimes it's not only the adenoid, or actually it's not the adenoid which is causing the obstruction. Hypertrophy of the inferior turbinates can be found in children. You should consider hypertrophy in the inferior turbinate. And this is one of the values of the doing endoscopy for the child. You will know if the cause of the enlargement is because of the nasal obstruction is because of the enlargement of the inferior turbinate, or it's because of the adenoids. Also, you should consider the presence of choanal atresia. A child with unilateral choanal atresia may pass unnoticed and undiagnosed for a very long period of time. And this child, if he gets a plain X-ray, he may be diagnosed with adenoids, put to sleep, and then you will accidentally discover that he is already a child with unilateral choanal atresia. One of the most important points that you should put in mind while you are examining your patient is the submucous cleft. A child with submucous cleft, if he undergoes adenoidectomy, will end up by velopharyngeal insufficiency. And how to diagnose a submucous cleft? There are three signs. You have a bifid uvula, a zona pellucida, or a white or a clear zone between the levator muscles, and if you palpate the hard palate, you will find a notch at the side of the posterior nasal spine. Sometimes you don't get this classic view. You may not get the bifid uvula or the zona pellucida. However, the notch at the posterior end of the soft palate is a fixed mark. So if you find it's a step that you should do every time you're going to do adenoidectomy, please palpate the hard palate, palpate the soft palate, and detect if there is any submucous cleft. What would I do if my patient is put to sleep and I found that he has submucous cleft? If there is persistent bilateral nasal obstruction and you want to treat it, do superior adenoidectomy. Remove only the superior part of the adenoids. If you are not acquainted with the equipment, because you cannot remove only part of the adenoid with an adenoid curette. To do this procedure, you have to have a suction diathermy or a coblation. If you don't have this equipment, please awake your child. Don't do the surgery. So now to the main point about the operative procedure. Of course, we all know that there are too many techniques that we can use these days for performing adenoidectomy. You can do it with the coblation, you can do it with the suction diathermy, you can do it with the microdebrider. However, still up till now, the most common technique of performing adenoidectomy is adenoidectomy using the curette. And this is why I want to emphasize this technique and talk about it. This is the oldest type of adenoid curette. It was invented by Dr. Gottenstein in 1886. This is the precursor of all types of adenoid curettes. And later on, other types of adenoid curettes have been formed. The most common two types that we use these days is the Beckman and the Beckman adenoid curette and the Brunhill adenoid curette. And I want to address your attention to this small knob or small depression, at the handle of the adenoid curette, and I will tell you what's the function of this or how can we use it. All adenoid curettes, they have different types and different shapes and different angles. They all satisfy the same purpose, is that they take a little bit the contour of the curved contour of the nasopharynx, and they have a sharp edge which is going to use to shave out the adenoid from its bed. Also, there is another type of curette that was popular sometimes. It's called the St. Clair Thompson curette, and this curette has teeth inside a cage with teeth. This curette was used in the past because at the early beginnings of doing the surgery, it was done under local anesthesia, under general anesthesia with ether, without endotracheal intubation. So if you're going to curette the adenoid and it slips down into the airway, it's going to be a problem. So this is why the cage was invented, to prevent slipping of the adenoid tissue into the airway. However, this is not a very commonly used instrument these days because it's a little bit bulky and it's cumbersome. If you are going to use an adenoid curette, you have to keep your adenoid curette sharp. And to do this, there is no recommendation about for how long can you keep your adenoid curette and when do you need to sharpen your curette. However, I would say about every, it depends on the your
Rate.
cases and number of your cases. But always you have to check your adenoid curette and you have to make it sharp. You can do this with a professional, take it to somebody who can do it, or you can do it at home. You can take a hand drill that we use in at home and use this kind of polish, and then you can polish your adenoid curette by yourself so that you can make it sharp. من التول شوبس، اي تول شوب فعالية دي جميلة. Also, two other important instruments. Use whatever type of a mouth gag that you think of, but always use a mouth gag that has a slot or a groove for the endotracheal tube. Okay, this is very important. The old type of blades which doesn't have this groove will compress the endotracheal tube while doing the surgery, and your anesthesiologist will not be happy with you. Also, you have to have this bayonet shaped with double curve bipolar forceps. It's very handy, and it can reach up in the areas of the nasopharynx. Now, a few points about anesthesia. You are doing a surgery in the airway shared with the anesthesiologist. You have to be confident in him, he has to be confident in you, and you are working as a team. First, intubation for anesthesia in cases of adenoidectomy should be oral intubation using ray endotracheal tube. In the past, we used to do adenoidectomy while the patient is nasally intubated. This is something that should stop, and any patient who will undergo adenoidectomy or tonsillectomy should be intubated using ray endotracheal tube, oral tube, and the mouth blade of the mouth gag should accommodate the endotracheal tube and push it upwards with the tongue away from your feet. Also, another important point is that always do the surgery under deep anesthesia. Do not do the surgery under light anesthesia. If the anesthesia is light and the patient is swallowing, the muscles will be contracting, and then you are going to injure them, and then you will have a post-tonsillectomy bleeding. Post-adenoidectomy bleeding. So always ask your anesthesiologist to keep the patient in deep anesthesia. Now about the surgical steps, this is the way how I do it. First, the patient is lying flat, nothing under his shoulders, the mouth gag with a slot, taking the endotracheal tube upwards with the tongue, and then I will put a catheter through each side of the nostrils, and then I will hold them back so that I can pull the soft palate upwards, so that I can have an unobstructed view towards the nasopharynx. I'm at the back of the patient, from the head side of the patient, but I can see at least 50% of the adenoid. What I think is that adenoidectomy, I have to stop here. Adenoidectomy has been always done as a blind procedure in which you can see nothing. the soft palate is there, and you are just feeling with your fingers. And I've been always told by my seniors, feel with your finger if there is a remnant of the adenoid. Feel with your finger how is the size of the adenoid. I think this is something so crude. You cannot assess the size of the adenoid with your finger. You cannot differentiate between the muscles, between the adenoid remnant with your fingers. You have to see. Actually, the proper way of doing adenoidectomy is not this. The proper way of doing adenoidectomy is doing it endoscopically assessed. You have to see what you are doing. But because I know most of us will be working in places in which the presence of an endoscope and a camera and a monitor will not be available, we have to at least put ourselves into the best conditions that we can see the maximum of the adenoid. So at the beginning of the procedure, I'll be at the head of the patient, at the head of the table, and I'll be looking down into the adenoid, pulling the soft palate away so that I can see at least 50% of the adenoid before I put my adenoid curette. And then by sweeping motion, pushing on the adenoid towards the downwards towards the larynx, you will get your adenoid out. You can never teach someone how much pressure you need to press on the adenoid bed so that you can curette. This is something that you will get by experience. If you have a sharp curette, you don't have to use much of the pressure. And classically, this step should be done with your right hand, if you're right-handed, while your left hand is put over the shaft of the adenoid curette, so it can work as a fulcrum, so that you can stabilize your adenoid curette while you are curetting. This is why in the instruments we have found a place, a depression, where you can put your thumb, so that you can put your thumb in while you are curetting, so that your thumb will work as a fulcrum. Okay? You may need 2 or 3 sweeping motions before you can remove the adenoid completely. So I'm curetting again because I've seen a remnant. And then I'm going to put a dry goes back. I will leave it there for about 5 to 10 minutes. If I'm going to do tonsillectomy, I'm going to do tonsillectomy and then come back and see. If I'm going only to do adenoidectomy, I'm going to leave it for about 5 to 10 minutes. Then this is what I do a little bit different. At the beginning of the procedure, I'm at the head of the table with my patient lying in front of me. When I'm going to look if there is any remnants of the adenoids, I'm going to do a hemostasis. I go to the side of the table so that I'm looking to my patients face to face. So what we usually used to do is that you will perform hemostasis while you are still at the back, while you are still at the head of the table. You can never see the bed of the adenoid while you're standing there. Unless you have a 30 degree or a 70 degree endoscope, you can never see the bed of the adenoid. So the only way you can see it is that you can come to the side of the table and you have a look directly into the operating bed. Okay, so this is the same way that I will be looking at the patient. You will see almost like 90% of the adenoid bed. You can detect remnants, you can detect any bleeder, and then you are going to cauterize it by bipolar diathermy under vision. Okay. So I'm going to remove the adenoid back, and I will hold 2 instruments. I will hold an artery forceps with a sponge in my hand, and the other hand I'm going to hold my bipolar forceps, so that I will clean the area using the cotton, and then the area which I suspect is bleeding, I'm going to cauterize it under vision. So by standing face to face to the patient, you will have access to the adenoid bed, and you can see it, and you will almost be sure that you are not leaving remnants and you are not leaving a spurter or a bleeder behind. And then, after making sure that everything is dry, I'm going to put a piece of cotton soaked in saline adrenaline 1 to 10,000. Okay, so it's one ampoule of adrenaline 1 milligram over 10 cc's of saline, and then I'm going to put it over the bed for about 2 to 3 minutes with some light compression. And then I will put some H2O2 into the adenoid bed, and I'm going to leave it also for 2 to 3 minutes. Why do I use hydrogen peroxide? Number one, it's an antiseptic. It's good to clean the area you're going to deal with, especially if it is an open area. It's going to be in contact to the outside atmosphere. Number two, it causes it can seal and cauterize very small blood vessels. And number three, and this is what I think is important, is that when you use the hydrogen peroxide cottonoid, it's going to soak the area with this white color, so that when you remove your cotton, if there is any still bleeding spot, you will detect it, you will see it very quickly, and you will see this in a minute. This is the adenoid bed as I can see it after ending the procedure. I can see almost 90% of the adenoid bed. The only part which I cannot see is the quena and the area of the vomer. I'm going to inspect it just in a minute. However, the whole adenoid bed is in front of me. This image was taken by my mobile phone. This was not taken by an endoscope or anything. This is the same way that you're going to see it if you stand to the side of the patient face to face. Don't do the procedure while you are at the head. You will do it up blindly. You cannot see the bed. You cannot see your operative area. So after using the hydrogen peroxide, the area looks like this. If there is any bleeding spot that's still there, you can see it, you can detect it, and you can cauterize it under vision. Then the only area which I could not see clearly is the area of the quena and the vomer. So I will use a mirror so that I would be pretty sure that I did not leave some adenoid tissue at the quena, and which is going to develop recurrence or enlargement of the adenoid again. I put the mirror and have a look. You can see the vomer. You can see the quena on both sides. Okay. It's clear. And at the end of the procedure, I would do some suction through the same tubes that I've used to retract the soft palate from both sides, so that any remaining blood in the nasopharynx will be clear. And the final step is that I put some Atrovine or any decongestant nasal drops. And actually, why I'm putting these drops is not because of their decongestant effect. Still, I want to make sure that there is no bleeding. So if I put these drops and they come down the nasopharynx into the oropharynx and they are clear without any traces of blood, I'm pretty sure that there is no bleeding in the nasopharyngeal area. So as you can see, there are repeated steps making sure that there is no bleeding. First I cauterize, then I put ephedrine back, and then I will put hydrogen peroxide, and then I will suck from the nasopharynx, and then I will put the decongestant nasal drops to make sure before the patient is awake that there is no chance for the patient to have post-adenoidectomy bleeding. Of course, nothing is 100% guarantee, but I think in doing the adenoidectomy in this way will keep you to some extent safe. Now, what about the post-operative care? The usual care, I would encourage my patients to eat as soon as possible, because if you have done already tonsillectomy, you give the regular diet regime. If only adenoidectomy is done, there is no precautions about diet. You can start regular diet as early as possible. Of course, good hydration is important after any kind of surgical procedure. I would only give analgesics in a mild dose, paracetamol or something, for a few days. Adenoidectomy is one of the most common procedures that we do, and I think by doing it in this technique, this is the way I do it, by doing this procedure and this technique, I think we can have a safe surgery. Thank you.